could probably take 2 days to talk about these concepts, but let me see if we can get through most of it in the next 25 or 30 minutes. So we'll chat a little bit about COVID-related acute lung injury and hypoxia. I'm sure it's been a theme today, so I'll try not to labor the point too much, and we can kind of highlight what the differences are, if any, as it relates to a more traditional ARDS patient. We'll talk a little bit about ECMO and its application in ARDS, and then lastly, we'll chat about the Cooper ECMO experience throughout COVID. But we'll start with the case. So we have a 59-year-old male with a past medical history only for hypothyroidism. He's a previous critical care nurse, now working as a nurse manager in an outpatient nursing facility, and he presents with worsening dyspnea for about 3 days. Has fatigue and myalgias that he kind of thinks back over the last 2 weeks, and actually presents to us through the ER with a known diagnosis of COVID, that he was PCR positive in an outpatient testing facility. So on arrival, although a little dyspneic, doesn't look bad. Vitals are otherwise stable, and for being a robust and athletic guy with no oxygen requirement, now has a 4-liter oxygen requirement, but maintaining a saturation. Otherwise, worker breathing isn't bad. If you look at his chest X-ray, sort of early presentation in COVID, it's pretty classic. You can see, kind of mild but prominent multifocal infiltrates in the upper and lower borders of the lung. Okay, so gets admitted to the general medical floor. Over the next 3 days, though, he progresses, and we saw this with a lot of our COVID patients early in the surge. So got stepped up from nasal cannula therapy to high flow oxygen in order to maintain a decent oxygen saturation, and we were really involved early in his care. As he was on high flow and doing everything that he was supposed to do, trying to minimize his work of breathing so that he doesn't have any additional forceful injury to the lung. He was self-proning, so all of the things that we think are beneficial and kind of redistributing the way that we oxygenate and ventilate with prone positioning in our ventilated patients, we applied that therapy very early in our COVID treatment for patients who were on either nasal cannula or high flow oxygen. So he did everything that he could do, but he was highly inflamed and progressing very quickly. And at the time, he got, the cocktail of medications that we had available, which were immunomodulator therapy in combination, which at the time was all we had for what we thought was antiviral therapy for hydroxychloroquine and Kaletra, both of which are no longer used. But this was his sort of this was our approach, basic medical therapy with oxygen and supportive care, while we try to, to ride out the wave of acute lung injury and COVID. But you can see sort of progression in his lung disease. So that was his admission X-ray on the left side. And 3 days into this course, that's his X-ray on the right side. And unfortunately, by day 3, you can see that he was more and more hypoxemic, labored breathing, really, sort of fell off the edge at right prior to intubation. And based off of his X-ray and his blood gas, you can see is on 40 liters and 100% FiO2, he was only his PaO2 was only 83. So his PF ratio at the time, prior to invasive mechanical ventilation, was under 100. So looking at his X-ray, looking at his presentation, he had severe ARDS, and there was really no reluctance at that time to take over some or all of the work of breathing with invasive mechanical ventilation. So you can see that X-ray on the right side was right after intubation, and he had pretty progressive lung disease. So just a recap, when we talk about mild, moderate, and severe ARDS, it's important to know what the Berlin criteria is for ARDS, and whether it's COVID-related lung injury, influenza, bacterial pneumonia, or non-infectious mediated lung injuries for any of a number of inflammatory states. It's really about tempo, the degree of lung injury being bilateral multifocal infiltrates, this being a cardiac lecture series, making sure that it's not predominantly due to left heart failure. So this is non-cardiogenic edema or pulmonary capillary leak. And you look at the PF ratio, or the degree of arterial oxygenation for the amount or fraction of oxygen that you're delivering to the patient. So under 100 is severe, and that's certainly where he was. So, when we talk about, hypoxia and acute lung injury in the setting of COVID, you know, I think that we had a lot of benefit, here at Cooper through the experience and expertise and mentorship of some of our senior faculty, particularly Dr. Dellinger, being able to collaborate with colleagues in both China, Italy, in the early experience. I mean, we're talking in February about trying to best understand, what this sort of novel pathogen does and whether or not there's novel lung injury. And I think, if you got caught up in all the different phenotypes and the presentations and oxygenate, don't intubate, intubate early, intubate late, all these things sort of, there was concern that there was something very special about the ARDS, or the lung pathology related to COVID. And at the end of the day, although the pathogen was novel and some of the injury pattern more pronounced, and we'll talk about that in a second, ARDS is basically ARDS. Whether you look at it, histopathologically, for bacterial or viral infection, whether it's SARS or MERS, other coronaviruses, or whether it's influenza phenotypes, you're going to have sort of a mixture of alveolar or air sac injury and a combination of capillary injury or endothelial activation. And I think you guys have been touching on this throughout the day. For hypoxia and acute lung injury, one of the things that you see early that people talked a lot about in COVID was this sort of, you have a less symptomatic patient with a higher degree of hypoxemia, and a lot of that has to do with the endothelial activation and this high degree of dead space ventilation, or what we refer to as, the ability to exchange gas happens at that alveolar capillary interface. And if those capillaries are all blocked up due to activation or microthrombosis, you're not going to be able to exchange gas very well. And then as the native infection plus the secondary inflammatory cascade takes over, you start to see breakdown of those air sacs, and they start to fill with fluid, and then it's ARDS off to the races. So there is, whether it's binding, activation through ACE2 receptors, and then the secondary, even post-infectious mediated inflammatory cascade, the cytokine release syndrome, these things that you hear about, very prevalent in ARDS across the board. But we've been watching it, tracking it, and in COVID-related disease throughout this pandemic. So it's very much a topic that comes up over and over again. And even after you clear infection, this cytokine-mediated injury to the air sac, the lung, continues to propagate. And one of the reasons why we use immunomodulators and we provide support, waiting for that to calm down and then the lungs to heal themselves, hopefully. So it's a combination of both micro and macrovascular thrombosis. And I think we just saw a case of pulmonary embolism. We dealt with this throughout the entire pandemic, and you certainly see a high degree of microvascular thrombus. Again, you see this in other ARDS post-mortem analysis, but very prominent in COVID-related lung injury. It has a lot to do with early hypoxemia. And then, you combine that with, alveolar injury leading to diffuse alveolar damage. And this is how they get so sick so quickly. And then even after you clear infection, you still have this continued hit by the immune system that you hope to control while you wait for lungs to clear. So this is what's happening in our patient right now, and why he continues to progress, although coming in, mildly symptomatic over several days, was requiring full support with mechanical ventilation. And we'll just focus on lungs, but this happens in any of a number of other of tissues and organs related to COVID injury. So the approach to ARDS, and I think this is what was very important, when it came to our critical care team developing sort of an evidence-based approach to how we're going to manage it, is not get caught up so much in COVID as a pathogen, but think about the way that it hurts the lung, and understand that at the end of the day, ARDS best practices for supporting lung injury, whether it's from viral or bacterial or non-infectious mediators, I think is where you have the ability to make the biggest impact on outcome. And that comes with ARDS best practices. So that's how we manage this patient early with a low volume ventilatory strategy, right? I mean, positive pressure ventilation, for everything that you can do to save a life with a ventilator, you can equally harm a patient over time because we're not naturally built to breathe positive pressure. We're negative pressure breathers. And as the lungs become more inflamed, heavier, they start to lose that that degree of compliance and have increased elastance. Blowing in a pressure breath can cause injury to those air sacs that over time can be irreversible, and that's where a lot of the mortality comes in severe ARDS management. Trying to make sure that we keep those air sacs open, that we adhere to certain pressure parameters. I'm not going to get into driving pressure too much, trying to limit the patient's interaction with the ventilator so that they don't hurt themselves, because it's an uncomfortable sensation. So utilizing paralytic therapy and things like that early, for all of the pluses, there's certainly downsides to that therapy. And then utilizing prone positioning, all these things we did for this patient. And that really, when you think about the therapeutics and what drives people to survive this disease, that's really the cornerstone. And then everything else that kind of came along, whether it's corticosteroids or IL-6 inhibitors, you guys, I'm sure, talked a lot about this. I mean, I think some of the best stuff that came out was the use of corticosteroid therapy to sort of help control this post-inflammatory cytokine-mediated injury. And whether or not you do a targeted IL-6, you can argue back and forth with some of the newer data. I'm not here to do that right now, but corticosteroids, certainly the use of systemic anticoagulation, a lot of these things we were lucky enough to adopt early, because we were in constant contact with people all over the world. And I feel, this is one of the best mentorship experiences of my life. Utilizing anticoagulation for those reasons we talked about for endothelial activation. And then whatever came along, utilizing remdesivir as, kind of a broad spectrum antiviral therapy over time, and then convalescent plasma. I'm not going to get into that right now, but the list of therapeutics goes on and on and on. A lot of them very difficult to tease out much of a signal of benefit when you get into the severe population that's largely post, viremia, and on the back end of clearing virus, but now left in this state of, what's more or less like a house fire in your chest, and trying to put out that fire and then allow for healing without having the patient just completely uncouple over time, from an organ system standpoint. So that's ARDS management in a nutshell, specifically in COVID-19. So let's get back to our patient. So he was started on a low volume ventilatory strategy. He was paralyzed. He was maintaining a euvolemic state, to try to minimize, the degree of hypoxemia. He underwent prone positioning, sometimes for prolonged periods of time, but had frequent episodes of mucus plugging and desaturations. So it was very challenging to keep him prone, as the disease got worse, because you have a lot of sloughing of airway mucosa in some of these patients, and they easily plug and then have, almost fatal hypoxemic events. And then he also, unfortunately, developed a concomitant bacterial pneumonia. So now he has a second hit to his lungs with methicillin-sensitive Staph aureus. So he really wasn't doing well. And you can see that, from progression from the time of intubation to densely infiltrated lungs, with a worsening degree of both hypoxemia and CO2 retention. So at that point in time, the ECMO team was consulted because he was at a place right now where we couldn't oxygenate him, we couldn't ventilate him, and his airway pressures were so high that we were going to cause significant irreversible damage to the lungs. So he's at a place where he has failed mechanical ventilatory support. And absent some other form of support, he has a 100% mortality. So what do we do? And that's where the discussion of ECMO started in this patient. But before we talk about ECMO and COVID, let's just talk about ECMO and ARDS in general. And some of you guys might have some experience with ECMO. You may have a lot of experience with ECMO, or you might not even know what ECMO stands for. So it's extracorporeal membrane oxygenation. And it comes in a variety of flavors. There's lung support, there's hemodynamic support, and there's a combination of lung and hemodynamic support. I could talk for an entire day about ECMO, but let's just focus on veno-venous ECMO or lung bypass, right? Because that's what we're doing. We're at a place right now where we can't use the native lung in order to oxygenate and ventilate the patient, we're going to have to use a mechanical lung to do that. And we failed a positive pressure mechanical lung, so now we're going to have to use an extracorporeal membrane lung. Does that make sense to everybody? I hope so. I'm here to answer questions afterwards. I'm just moving kind of fast. So here's a basic circuit interface. You're going to drain blood from the body. You're going to push it through a membrane lung where you're going to exchange CO2 and oxygen. And then you're going to push it back into the body. So this is a classic two-site cannulation configuration where the patient has venous blood being drained from the IVC out through the groin, gets put through the ECMO circuit, and we'll talk about that in a second. And the highly oxygenated blood gets pumped back to the right side of the heart, where it's pushed across the left side of the heart out to the lung, largely bypassing the native lung completely. You can provide 100% support with the ECMO circuit, and we still use the ventilator to a certain extent to give us some adjunct support, because some of these patients are so sick and your ability to provide enough flow can vary. So selection is everything, right? This is not a therapy, right? ECMO is not therapy. ECMO doesn't fix anybody. ECMO gives you time. It buys you time to try to survive whatever injury or insult puts you on ECMO to begin with, okay? Yes, there probably are some secondary benefits to being able to really limit the amount of ventilator-related injury, because you can really step down the ventilator support and the pressures on the ventilator. So you may think about it sort of secondarily, but try not to be distracted. ECMO is not therapy. There's nothing that the ECMO circuit does to get you better. It buys you time to allow you to heal yourself, right? So you really have to select appropriately. That means that all patients don't die on ECMO, right? Just because you can put them on ECMO, you have to be able to see this as a bridge to survival. And if the patient has sort of multiple comorbidities in a multifunction or in a multifactorial, organ failure state, this might not be a survivable case, and supporting them with ECMO may be futile. So this is where you really have to tease out some of the relative contraindications as much as the indications to place someone on ECMO support, because there really aren't any agreed upon contraindications when it comes to ECMO, outside of just being able to identify that this person isn't going to do well. So if they have a terminal cancer, or their age has been a cutoff that moves back and forth and can be very patient centric. So I'm not going to comment too much on that. And certainly if you've been riding the vent for 30 days and have trashed your lungs to a point where the likelihood of recoverability is low, probably ECMO is not going to get you anywhere. It's just going to prolong the inevitable. So selection is everything. There are certainly patients who, not everyone with COVID disease who progresses to the point of, of terminal lack of response to mechanical ventilation is a candidate for ECMO. But we're going to do our best for the people who can. And that was sort of the point. And that goes with ARDS in general for ECMO. So the type of machine you use, they come in a variety of different flavors, and they're built, these are all the machine interfaces that are going to work the pump. They're just kind of built around what you need. So whether you use the one on the left, which is really great for transport, the one in the middle, which is the one that we use, or the one on the right, which you can combine with the tandem heart if you're doing bad therapy and whatnot, you pick your machine sort of based off of what your needs are. But there's nothing special about one machine or the other, right? It draws blood out, pumps it back to the patient, and kind of monitors, how you optimize flow based off of that. So one isn't better than the other. The pump in and of itself has come a long way, from rollerball pumps, which you see on the left side, which are sort of mechanically driven, like it says, balls that roll around and, drive blood out and push blood forward. You may see this a little bit in pediatric ECMO, but you no longer see it in adult ECMO, because that mechanical driver, doesn't really have any feedback mechanism when pressures escalate. So you can cause your whole system to explode and spray blood everywhere if there's a lot of afterload. And at the same time, you can cause a lot of mechanical trauma to the blood cells, resulting in hemolysis. So the centrifugal pump, or the pump that sort of sits on a magnet and spins, which is what you see over here on the right side, is what we use now, and functions much like the cardiovascular system, with your ability to kind of toggle through the cardiovascular system with a dial. So it's going to be preload dependent, meaning you have to be able to have enough volume to drain to get the flow that you want, and it'll be afterload sensitive. So if the afterload starts going up, your ability to flow forward will be impacted. And I think that that's important because it very much mirrors what our cardiovascular system's meant to do. So that's our pump. And then the membrane lung, which I think is the most unique part of all of this, has really come a long way. I mean, I love to talk about the history of ECMO, and I love to chat about John Gibbon and the advent of ECMO, which was very much local here, starting at MGH. But he's a Jefferson guy, and much of the advent of the heart and lung machine started at Jefferson. But you have these hollow membrane tubes that you're going to pump blood across, and you're going to blow air in and oxygen, and it's going to interface with the blood, and you're going to pull off carbon dioxide, and you're going to oxygenate the blood. It's very, very, very efficient. When you think about the surface area of the human lung, which is around 70 meters. So if you unravel a person and look at the surface area of their lung, it's about 70 meters. And the surface area of the membrane lungs under 2 meters is about 1.5 to 1.8, depending on the size of your membrane lung. And yet you can fully oxygenate, fully ventilate someone at 7 liters of blood flow and be much more efficient than the lung, which in part of the way that you have to tweak, how aggressively you pull CO2 off sometimes can have an impact on how people do. We don't have time to talk about that, but it's a really, really impressive where the membrane lung has come, since the 1950s. And then the cannulas themselves, right? The drainage and return lines can come, for veno-venous ECMO can be placed a number of different ways. So classic two-site cannulation, you can see red meaning how we drain blood. Blue meaning how we drain blood, and red meaning how we return oxygenated blood to the patient. You can see a two-site femoral IJ configuration, which you'll often see in our ICU. You can do a femoral cannulation where you drain and return both through the femorals, just making sure that the cannulas are separated enough so you're not draining all of the oxygenated blood that you return, which is a term called recirculation, which can be devastating. Or you can use a dual lumen bicable cannula where you drain and return through the internal jugular in one site. And there's a lot of there's benefits and there's ups and downs to every configuration. We're not here to talk about that, but these are the things that you'll see. And the cannulas they're really big IV lines, so they range anywhere, for the adult patient from about 20 French to 30 French. So a common drainage cannula will be about 20, 25 French. So that's large, and that'll allow you to drain, and then you'll return through about a 20 French cannula through the internal jugular, and that'll be able, provided the patient has good volume status, allow you to maintain anywhere between 4 and 6 liters of blood flow. Putting these in a percutaneous fashion was something that we had to learn very quickly here at Cooper. And then the bicable cannula, which you'll see us use occasionally, commonly put in under fluoro, but can be done at the bedside under TEE guidance, which we had to do during COVID. Will drain and return blood through the same cannula, and there's benefits to that, and it allows you to be more mobile. Have a single site that you can worry about, but there can be, because you have 2 cannulas in one, you can be impacted on how much flow you can provide that patient depending on their need. And there's a lot, and I think the biggest thing to take away is, yes, I mean, it sounds very intuitive, you need to oxygenate and ventilate, so let's take it off and do it a different way, just like dialysis is dialysis for the lung, right? It comes with a whole host of complications, and supporting someone for a prolonged period with a machine that is very much not natural comes with a bunch of complications. So you're at just a higher risk of, if that patient is not an appropriate candidate for ECMO to begin with, killing them with ECMO. And at the same time, if they don't have the trajectory for improvement that you were hoping they would, a prolonged course comes with a host of complications that may ultimately end in their demise. So everything from stroke and bleeding, pneumothorax, cardiac arrest is a very difficult thing to do while flowing on ECMO. Thrombosis, pump failure. These are, on the right are all the things that we encounter strictly to the ECMO circuit, and we'll touch on a couple of those things. So, the idea is, if you can do this, select well, and provide a good support, the outcomes in ECMO and ARDS in general continue to improve internationally every single year. As the literature out there becomes better, as our training becomes better, and as we've really kind of gravitated to setting up lung resuscitation centers of excellence in patients who had 100% mortality, you're often able to heal, somewhere between 50 and 60% of them if done well. But in the face of complication, that slope takes a big downturn, where their risk of the opportunity for survival really falls off. And that's why continuing education, simulation training, and all these things that we do on a regular basis are so important for mitigating a lot of the complications that come with running, like I said, someone on a machine that is very not what the body was intended to do. And that machine, human interface is not as smooth as it sounds. Okay, great. And these are some examples of clotting. These ECMO circuits are heparin coated, and we run them on anticoagulation, systemic anticoagulation, and yet still you'll have blood clots that form in the tubing, and as soon as a blood clot forms, it gets kicked into that pump head, and then the whole thing just collapses. And you'll see someone go from, a 98% saturation to a 50% saturation very quickly. And at the same time, you can see all these little black dots in there that look like bugs. I mean, those are all blood clots in the membrane lung itself, and they'll collect over time and then really start to have the membrane lung itself deteriorate in how efficient it is. And you'll be changing these circuits out, sometimes frequently, depending on the degree of illness. And like we've talked about in COVID disease, they have this hypercoagulable state that was a real challenge when it came to supporting patients on ECMO, because of the risk for circuit collapse and then having to change that circuit out very quickly, where you have to clamp, take them off ECMO, cut, remove the old circuit, bring in the new circuit, piece it back together, and get flowing as soon as possible before they had a hypoxic cardiac arrest. So accidental decannulation happens. So these are all things that we prepare for through ongoing simulation training with our faculty and fellows. Because, like you can imagine, you're flowing in 5.5 liters of blood. This is a real picture from some of the ECMO specialists in Paris who have a really amazing both in and out of hospital ECMO support team. And so if you end up pulling that return cannula accidentally out of somebody's internal jugular, you can drain all 5 liters of their blood in a minute. So you're talking massive exsanguination. So being prepared to be able to mitigate that is really important. So the data certainly highlights signals of benefit. Like I said, in patients who are selected appropriately, whether it's H1N1 or the initial Caesar trial. This isn't Journal Club, so I'm not going to spend too much time going into this. One of the larger VV-ECMO papers was the OLIA trial, which didn't show a signal of benefit. However, what was really interesting about that was the high degree of patient crossover, from the conventional group to the ECMO group. It was as high as 28%, just showing that, people have utilized ECMO, for a long time, and certainly from a lung resuscitation standpoint since the late 1970s. And in a high volume ECMO center, are very comfortable, and they recognize the potential for as a life-saving support system. So there was a high degree of crossover in the study, and when you looked at the patients who crossed over, they certainly had a signal of benefit, otherwise would have died. Like I said, 100% of them would have died had they not received ECMO therapy. So it made, for any of a number of reasons, this was a difficult study to interpret. But at the end of the day, I think, when you sort of bring everything together, what matters most is being a sort of an experienced center. So if you're going to do it, you have to do it right. You have to have invested faculty, and you have to have a high sweat equity to build this program up and ride it out. So we'll talk a little bit about that. So we go back to our patient. So like I said, not doing well on the ventilator, failed conventional mechanical ventilation. The options at that point in time would probably be to allow him to go into uncoupled multi-organ system failure from hypoxia and low perfusion, and allow him to pass, which, probably a couple of years ago would have been our only option, or consider supporting him on ECMO, and considering, his high functional status, the fact that this was solitary organ dysfunction, meaning only his lungs were involved, The rest of his organs were holding on because, like I, organs talk to each other, and once one of them goes down, they start to have this uncoupling effect that's very hard to get back. He lined up to be a good ECMO candidate, so he was cannulated for ECMO. Initially planned for a 2-site femoral IJ cannulation, but due to an internal jugular hematoma, he went femoral. So I'll show you a couple X-rays. So here's an X-ray of his pelvis. So you have one line here. This is his drainage line sitting in the inferior vena cava. So he'll drain the deoxygenated blood through this line, and then the other line goes all the way back up to the right side of the heart, and he'll pump highly oxygenated blood back to the right side of the heart. So this is a femoral VV cannulation setup. Was one of the only ones that we've ever done, because usually they tolerate either dual lumen bicaval cannula for the IJ or an IJ femoral cannulation configuration pretty well, but due to a complication, we had to go with this, and he tolerated it really, really well. So let's talk about the ECMO experience here at Cooper as it relates to COVID. Worldwide, we weren't sure what we were going to do. And, we started talking about this stuff, like I said, in the beginning of February, when we were talking to friends in Peking and a couple of colleagues in Saudi Arabia who were all talking about this novel thing that was happening in Wuhan. And, and then quickly you saw it spread across the globe, and we knew that we were going to have to be ready, but we weren't sure about what therapies we could offer, right? Because, when you think about it, and you look at, at Italy and China and New York City, we had a terrible amount of, I guess we just had a lack of resources, a ton of sick people, not enough ICU beds. Everyone's talking about like not enough ventilators and trying to make ventilators out of vacuum cleaners and things like that. So, were we going to be able to use ECMO to support people, especially since we have a relatively young ECMO program? So our lung resuscitation program, started in June of 2019. So were we ready to support these people? You saw what was happening in New York City, and you were wondering, well, when it gets down to South Jersey, are our patients going to look the same? And there was no difference between the patients who got sick in Wuhan and the patients who got sick in Italy and the patients who got sick in New York and the patients who were sick at Cooper. They all had, progressive, devastating ARDS, and the question was, well, in the ones that we have an opportunity to sustain, can we provide that therapy? And are we going to? Because it was very uncertain, even locally, with some large ECMO programs like at Penn or Temple, no one was committed to provide ECMO support because we weren't even sure if we were going to have the resources available to us for physicians, for cardiac surgeons, for nursing, for respiratory therapy, when we barely had enough ICU beds to go around. And when you looked at some of the data, in China, the ECMO experience was highly variable. Patients got on a salvage therapy too late, didn't look like it was working out for them. There were papers published saying that, because you can have lymphocytes sucked up in the ECMO circuit, that lymphopenia was associated with worse outcomes. So people early in the, in the data was saying, people shouldn't be using ECMO. It's too resource intensive. People are going to die. It's probably going to harm them. Just don't do it. Ride it out. If you die of COVID, you die of COVID. And, and Italy wasn't doing it at all. So when it hit New York, we were all like, well, what are we going to do? Are we going to commit? And I think it really came down with taking a step back and saying, this is a novel pathogen, but not a novel disease state. We made the decision that we were going to be an ECMO program, so we had to adapt, and that really came with the entire team of critical care providers coming together, from our intensivists and our ECMO specialists to our cardiac surgeons, teaching us all how to cannulate, because we had to provide this at a much higher volume than we had anticipated. So we were going to need more. We only had three cardiac surgeons. So, I give a lot of credit, and I'm very grateful to Mike Rosenblum, to Rich Heiblum, and to Frank Bowen for taking the time to support us and teach us, how to get somebody on safely, let alone how to run the pump. From our nurses who had to commit to ECMO, which means, learning a whole new skill set from a nursing standpoint, as well as spending an incredible amount of time in the patient room, right? I mean, just think about that. Think about how much time you have to spend in a room now because the patient's on pump and needs so much more monitoring and so many more interventions. This was during COVID, where everyone was terrified, of getting sick, and it was a special thing to see. And then from a respiratory therapy standpoint, still the same thing. Everyone came together and said, we were going to do it, and it was going to be all sweat equity. And, everyone came in on their days off in order to grow the program and provide care. And out of it came, several abstracts that we're all looking on for an intensivist-led and cannulation, program that has had a lot of success. And thankfully, the rest of the country sort of went the same direction, and we were able to start to accumulate a lot of data to compare ourselves and our practices to. So this is a slide from the ELSO registry, which ELSO is probably, internationally is the largest society related to ECMO and has one of the largest data series. And it's one of the things that we also contribute to here at Cooper about the number of COVID-related cases. And you saw that, actually, despite the early data out of China and the lack of data out of Europe, that ECMO was working. And that the national and international survival rate was about 53%, which is pretty close to what we see in other ARDS disease pathways, specifically like influenza and H1N1, which sit around 60%. So Cooper ECMO data, when compared internationally, so we had, during the surge, we still have one patient on right now. During the surge, we cannulated 15 patients in 3 months, and our survival was as good, if not better, than the international survival, so about 58%. And I think one of the things that we took away from this is, dig deep and dig in, right? So, there's no clear maximum duration of therapy for ECMO. And when you look at, VV ECMO runs in general, you see the average duration, being somewhere between like 7 and 14 days. These patients are running much longer, just got together with some people and we were talking, between the Jefferson data and the NYU data. There's case reports of patients with 150-day ECMO runs, which is crazy if you would have talked to me about this 2 years ago. And being able to support somebody through all the complications that come through 150 days on pump, it requires quite a bit of sweat equity from the care team. And I'm not talking physicians. I'm talking, nursing, respiratory, and all the administrators who are able to juggle beds and juggle assignments so people can get the care that they need. Because I think at the end of the day, we are starting to understand more and more that the lungs have the ability to regenerate. You talk a lot about the early acute lung injury and this, exudative infiltrative ARDS, it then turns into fibrotic lung. And I think for a long time, people said, well, once your lungs fibrose, we're done. And, there's more and more things that come out that show that the lung does have the ability to regenerate alveoli, not just heal themselves, but probably make new alveoli. When you look at some of the functional recovery for severe ARDS, patients had normal, for the ones who were able to survive the hospital discharge 5 years out, had normal lung function. You also look at patients who had cancer and had complete and total, pneumonectomies or removal of the lung. And then you go back and you actually look at the volume of alveoli in the contralateral lung. It grew in number, not just in size. So there are things that we don't completely understand about the lung's capacity to regenerate, which is to say that if we're able in the properly selected patient, able to support them for long enough, well, maybe we can give them a chance. And I can tell you right now, the patient that we have on, he's day 75 of his ECMO run. There's probably been a conversation 3 or 4 times along this run about withdrawing ECMO support because he didn't look like he was going to get better. And now over the last 2 days, he's had a significant improvement in his lung compliance and his ability to oxygenate to the point where we're weaning ECMO right now. Now, again, he's been 70 days. He hasn't moved the muscle in 70 days. Will we be able to get him out of the hospital alive? I don't know. we're going to try. But at the same point, he's likely to come off of ECMO support. So like, there's a lot that we don't know. But there are significant complications, bleeding and thrombosis. I would have to say, if you take something away from ECMO and COVID, that's been our biggest issue: the propensity to clot, and then the propensity to bleed afterwards. To the point where patients can have significant pulmonary hemorrhage that's almost fatal, if not fatal in some cases. So you have to make sure that this is a bridge to somewhere. You've heard me say this like 12 times. The patient has to have a trajectory for recovery. It's not okay to, you don't provide ECMO in order to die on ECMO. And it's more than just having hope. It's about being able to risk stratify whether or not this person has a degree of survivability. And that comes with being in an ECMO center of excellence, where you have the support and the experience to be able to tease that out. One of the other things that I think was very unique about providing, both ARDS and ECMO support in COVID was the isolation. You have people who are the sickest people you've ever seen on novel therapies, and they're completely alone. Their families aren't there to be by them. This was a paper. This was an article published from Dr. Damath about what it was like to provide, family support, in this setting. Not having a family at the bedside to even understand or witness what's happening to their loved one was really a unique experience. I'll leave it at that. And it all comes back to multidisciplinary care. Like I said, this would never have worked without the way that we were supported from our cardiac surgeons, from our nurses, from our respiratory therapists, and from our perfusionists. Rob Rios, I can't say enough he practically lived in the hospital throughout the entire surge, slept in the call room so that we had enough, because we have to provide 24-hour perfusionist support to help run the pump. Really, really impressive. So let's finish up. So our patient was on VV ECMO for 24 days, complicated by life-threatening airway hemorrhage, to the point where he actually filled his both lungs up, and and clots had built up all the way past the vocal cords. So his entire lungs were cast in blood. So he was on full ECMO support. This is most often a non-survivable event when it happens. But because of a really talented interventional pulmonary group, they were able to cryoablate and pull plugs out for about 3.5 hours, and they reopened the large airways that were blocked with blood clot, and he was able to start ventilating again, and eventually was decannulated, underwent a trach, and at 58 days went to LTAC. So, it's still tough to look at this picture. He and his wife were really amazing. And this is a picture of him just 2 months later at the beach. And just had coffee with him a couple of weeks ago. And, hearing his story will forever change, what I think can be done for people. They're all great stories. And we love to focus on the good stories, but like I said, not everyone's a candidate for ECMO. We learned a lot, and we were happy and really proud of the way that the entire team was able to provide support for these folks, and we continue to learn and grow, as providers. Because we don't know how far we can push the human body, and how far we should push the human body. But provided that there is a sense of recoverability and sustainability, we're going to try to do what we can for people with acute lung injury here at Cooper, specifically patients with acute lung injury and COVID. This is our youngest COVID patient. He's 17. You can watch he has a rap video about COVID. It's F COVID. I had to block it out at the bottom. A very 17-year-old approach to surviving ARDS on ECMO. But it's a pretty interesting rap video. But yeah, so again, COVID doesn't discriminate. We talk a lot about the elderly population and the and the multiple comorbidities, but he was a pretty young, healthy 17-year-old kid, and he was super sick. So that's pretty much all I have to say. So I'm open to any questions you guys might have related to the use of ECMO and ARDS or ECMO specifically in COVID. Thank you.